Hello, hello. Hey, sorry guys. I hope you can hear me. Am I audible? Am I visible now? If yes, give me a thumbs up. Sorry for the initial glitch. So what I was saying is that I will be talking about general pathology now. The systemic pathology which has already been there, which I have not completed yet, I'll definitely do it to the bone, the endocrine you asked, either in Med channel or in my channel because uh, we have practical series coming up for you that might occupy much of the time in the Med channel, right? Am I audible? Yes, perfect, great. So today we'll be starting about general pathology, immunology, neoplasia, and genetics. If you have been with me from the Nischay batch, what I must have told you is general pathology is a stepping stone for us to understand systemic pathology. That's how it has always been, right? So most of the general pathology concepts, topics are always linked to systemic pathology, which you can easily reproduce and write from systemic pathology. But having said that, definitely there are topics in general pathology which need some assistance, and that we'll definitely start seeing from today, right? Okay, perfect. So we'll look at immunology, we'll look at neoplasia, and we'll look at genetics. Immunology, there is overlapping between microbiology and pathology. I'm sure you know that. Whatever is comfortable for you, whichever book is comfortable for you, write them. There are few topics in immunology which is much better in pathology. That is like graft rejection. Definitely much better in pathology because we'll read about the microscope a little bit. Amyloidosis, it's not seen in your microbiology. Read that from here. HIV, definitely I'll say go with microbiology. All the infectious disorder, go with microbiology. Fine. Okay. So we are going to talk about four types of hypersensitivity, overlapping topic, but I'll present whatever is there in pathology textbook, right? Let's start. Before going into the topic as usual, I'm going to ask you a few questions. I want you guys to answer. Can anyone tell me which type of hypersensitivity is called a cell-mediated hypersensitivity? Cell-mediated hypersensitivity. Type 1, 2, 3, 4. In which of the hypersensitive response you'll have antigen antibody immune complex in circulation. I'll keep on asking questions. I want you guys to answer so that we get familiarized to the topic and then we'll go to the answer writing part. In which type of hypersensitive reaction you will have excess production of IgE? Next question. If I say myasthenia gravis, what type of hypersensitive response does it fall under? Okay, simple four questions, right? I just asked you very simple four questions and most of you answered it rightly, right? Most of you answered the right answer, right? So now let's go into the topic and see what you have to write in the exam if they ask you about hypersensitive response. Very unlikely to come in a long answer question. Yes, it might definitely come in a short answer question. Write a short note on type 1, type 2, type 3 or type 4 for that matter, right? First, we'll go to type 1. First of all, please remember all the hypersensitive response is going to be a problem in adaptive immunity. The 1, 2, and 3 are a problem in the B cells. Fourth one is a problem in T cells, right? So hypersensitive response, we have the type 1 allergic response, type 2 autoantibody formation, type 3 is immune complex. Though Robinson every textbook says circulating immune complex, we also have planted antigen against which we have immune complex, right? Type 4 is cell mediated or T cell dependent, right? Rest everything is B cell dependent. This is only T cell dependent, right? Hi Krish, I'm good. Hope you're doing good as well. Okay, perfect. Now let's look at the type 1 hypersensitive response. Then from that we'll go to one by one. Type 1, like I said, it's an allergic mediated. There are, for every hypersensitive response, there are few keywords which are must to be in the part in the exam paper. It's immediate, it is IgE dependent, can be familial, may not be familial. It's not must you have to write about type 1 hypersensitivity only from the general pathology. All of you must have read about the asthma pathogenesis. Bring that also. Because asthma is a prototype for type 1 hypersensitive response, right? I'm sure you guys know that, fine. So we do have a genetic susceptibility. I can have an HLA mutation or mutation in the interleukin receptors or interleukins, right? Most of the time, allergen is an inhaled antigen or a pollen grain. I can have injectable antigen also. We can have food allergy also. There are lots of them. The most important antibody is IgE. The cell is eosinophil and mast cell. Okay, perfect. Now we have to look at the pathogenesis. The type 1 hypersensitivity pathogenesis is almost exactly same pathogens of asthma. That's all, right? So we have a presenting antigen, allergen, or a pollen grain is gone to the antigen presenting cells or the dendritic macrophages in the throat. If I take asthma as a prototype, right? And then it's been presented to the T via the T cell receptor to the T cell. Can anyone tell me what type of T cell is this? CD4 or CD8? CD4 or CD8? It is CD4, perfect, right? So once the CD4 cells binds, it will be converted to Th2 subtype. This is very, very important, right? So we have Th1, we have Th2, and we have Th17. The moment it goes to Th2 subtype, automatically the Th2 subtype T cells secretes multiple things. Among that, we have three important interleukins, which is interleukin 4, interleukin 5, and interleukin 13. Interleukin 4 converts the B cell, B lymphocyte to a plasma cell, which produces IgE. Because we know that T cells are always T helper cells, right? It produces IgE. Interleukin 5 for eosin, right? It brings eosinophil. And interleukin 13 produces a substance which damages the epithelium. That's the reason we have an itching feeling whenever we have an allergic response, right? It's a eotoxin. It's a toxin to the epithelium, and it will go and damage the epithelium a little bit, right? The moment interleukin IgE comes, that's a place where the sensitization stops. What happens? This Ig will go and bind to the mast cells. This is where the sensitization stops. That's the first exposure. During the first exposure, you will not have a symptom for any of the allergic mediated response, right? Okay. So only when it comes to the second exposure, that's a subsequent exposure. Obviously, as Aditya, I love AI, and when it helps you to present something well, please embrace it, right? So subsequent exposure, what happens is the antibody is always there on the antigen. The antibody and the Fc receptor is there, which is bound on the surface of mast cell. The allergen goes and binds to them, activates the antigen antibody complex only in the subsequent exposure, and that will degranulate, right? The pollen sticks to the existing IgE on the surface of mast cell, and they degranulate. The moment the mast cells degranulate, automatically there will be something called pre-stored substances, right? Histamine will be stored again, preformed substances, right? We have prostaglandins, leukotrienes, and there are newly formed substances also, right? The moment the degranulation happens, you'll have histamine, prostaglandin, leukotriene, everything will be released. This will cause the immediate phase response. Type 1 hypersensitivity always has two responses. There are two steps in activation: the first initial exposure, the subsequent exposure, and there are two phases of reaction. One's an immediate phase reaction, other is a late phase reaction. This is after the exposure second time. Immediate phase happens for within immediately, like 5-20 minutes. Maximum can last for 1 hour, that's all. Mediated by histamine primarily, but again the other things also might minorly contribute. A platelet activating factor, serotonin can contribute, but primarily mediated by histamine. Can anyone tell me what histamine does? I'm just pulling it down. Histamine does one simple thing: a vasodilatation and increase in vascular permeability. Same thing happens here, right? So histamine primarily does the vascular leakage, vasodilatation, and subtle amount of the bronchospasm also, because leukotriene also might contribute to a little extent, right? Late phase response is primarily mediated by WBCs, the newly incoming WBCs, which happens 2 to 8 hours later, right? These are due to infiltration of the tissue by eosinophils, neutrophils, basophils. Any interleukin which has been secreted are all chemotactic factors. Leukotriene B4 is a powerful chemotactic factor, right? They will attract more WBC. When that WBC comes, they also have granule content. They also will degranulate and have the same response a little bit later. We call it a late phase response, right? Perfect. I'm just going to zoom out a little bit. We have everything required here from the sensitization, the next the re-exposure, the immediate phase response, and the late phase response. Sorted. Then few examples. This will be the template. Tell what it is. Tell a template pathogenesis that's allergic related, asthma related, and give me other examples. Can anyone tell me any other example of type 1 hypersensitivity? Whatever comes to your mind. Whatever comes to your mind. Examples? There are lots of examples, right? Every allergy, whatever comes to your mind is an example of type 1 hypersensitivity. Could be an urticaria, itching in the skin, atopic dermatitis, allergic rhinitis, insect bites. Lots of them are allergic related, right? The most important thing, this can come in a one-liner or in a viva. Contact dermatitis. Can anyone tell me what type of hypersensitive response is contact dermatitis? Is it type 1, type 2, type 3, or type 4? Contact dermatitis is perfect. It's a type 4 hypersensitivity. I'm writing here itself. Contact dermatitis is not type 1 hypersensitive response. It's a type 4 hypersensitive response. But an allergic mediated dermatitis is a type 1 hypersensitive response. Kalpana, great. Anaphylaxis is something which is an outlier of type 1 hypersensitivity where I do not have the sensitization phase. Even the first exposure can trigger a massive response, that is anaphylaxis. Sudden onset, which can easily cause edema of the airway, and we can even lose the patient. One of the most important trigger why anaphylaxis happens, you must have read lots of the places there, we have bee stings. Yes, bee sting is one of the important examples for anaphylaxis because pollen grains is going by the nasal cavity. Food I eat, skin, I have contact of the allergen. But a bee sting introduces the antigen directly into the systemic circulation, or an IM injection into the blood directly. Whenever the dose of the antigen is very high, the first sensation phase can be skipped and it will automatically go to the subsequent phase of activation, and that causes anaphylaxis, right? Okay, that's the first thing, the type 1 hypersensitivity, right? Now let's go to type 2. Before going to type 2, as usual, few questions. Let's see if you can answer. Can anyone tell me what are in type 2 there are multiple subdivisions. Can anyone tell me any one subdivision of type 2 hypersensitivity response? Or let's start with the easy question. Any one example of type 2 hypersensitivity response? Examples. Any one example. That's 3 subtypes of type 2 hypersensitivity. Any one example. Okay, I want to guess comment and let's take it from here. Type 2 hypersensitivity is an autoantibody formation. The majority of the autoantibody formed by default is IgG autoantibody. That's why when you go to hemolytic anemia, the type is IgG, that's all. When you go to ITP, the most common is IgG. When you go to Goodpasture syndrome, the most common is IgG, right? Yes, I can also have IgM, cold autoimmune hemolytic anemia, IgM, right? I can have. But the commonest one is always IgG, followed by IgM and others, right? So here we have 3 ways by which my body can destroy using autoantibody, right? Like Anshara said, ADCC, right? Antibody-dependent cytotoxicity is one of them by default, right? Based on the location of the antigen, my body responds in different way. When I have antigen on a cell, like RBC, my macrophage can come, eat the cell. That's the first one, opsonization and phagocytosis, right? If it's on a cell, what happens? IgM binds to the RBC, eaten by the macrophages, right? It can be IgM or it can be IgG. If it's IgM, it will always combine with complement. IgM cannot act alone, it will always combine with the complement, right? Every autoimmune hemolytic anemia has type 1 opsonization and phagocytosis. Like Kalpana said, your erythroblastosis fetalis, you must have read in your first year itself, right? The RH incompatibility is a type 2 hypersensitivity, opsonization and phagocytosis. ITP, type 2 hypersensitivity, opsonization and phagocytosis. The only thing is here, the location is on a cell where my body can go and eat the cell. But let's say if the location is on a membrane, like a blood vessel, macrophage cannot go and eat a blood vessel, right? Basement membrane, macrophage cannot eat it, right? So what happens? Whenever I have an antibody which is on the surface of a membrane, my body will activate complement and cause inflammation and cause destruction, right? That's complement mediated inflammation and destruction. It happens whenever you have the inflammation, the surface will be on a surface, not a cell. If the antigen is on surface, antibody binds to it, antibody by default activate complement, complement will attract C3a, C5a, that will attract more WBC, that causes destruction. Any surface, this example, ANCA mediated vasculitis, acute rheumatic fever in the heart, right? That's also a short note by the way, right? Goodpasture syndrome, when you have antibody against type 4 collagen, or anything which comes to your mind, when you have antibody against a surface, it is going to be complement mediated inflammation. Hinotsuka and purpura, same, right? So anywhere, Kawasaki disease, I have antibodies against endothelium, same way I'll got destruction, it's against a surface. The third subtype is antibody mediated cellular dysfunction. Remember, dis means abnormal. Here antibody is not destroying anything, it's altering the function. How can I alter the function? I can go and sit on the receptor and block it, or I can go and sit on the receptor and activate it. Both of them are dysfunction, right? Fearless, I've told it in start, will definitely do it, fine. Okay, so when I have myasthenia gravis on a neuromuscular junction in the acetylcholine receptors, the autoantibody goes and binds to it, destroys it, and causes a myasthenia gravis. The same way in Graves' disease, I have TSH receptor, the antibody goes and binds here, and they cause activation of the receptor. We call them thyroid stimulating immunoglobulins, or TSIs, right? So when TSA is there, I'm going to have activation of the TSH receptor. My body will automatically start producing more and more and more thyroid, resulting in hyperthyroid state, right? I'm going to zoom out again. It's a very simple way. See, an exam is about presentation and obviously an equal contribution of knowledge. We know what is the antibody involved. Give an example, write a one-line definition that's in type 2 hypersensitivity is mediated by an autoantibody production against antigen in different parts of the body. Most of them is IgG, and there are 3 subtypes under that. When there's antigen on a cell, I eat them, I destroy them. When the antigen is on a surface, I bind with them, cause inflammation, or I can deactivate or an activate a receptor causing dysfunction, right? Perfect. Now let's go to type 3 hypersensitive response. As usual, few questions I want you guys to answer. Give me a prototype example of type 3 hypersensitive response. One prototype example of type 3 hypersensitive response. Everyone knows, right? No one is going to ever forget SLE, systemic lupus erythematosus, right? The type 3 hypersensitive response, how it was discovered was not with systemic lupus erythematosus, was discovered by injecting horse's immunoglobulin. Long years back, when there is a snake bite, I use horse immunoglobulin to attack it and destroy it. Now we have recombinant antibodies and multiple other things, right? Previously, it was only horses. When I gave horse immunoglobulin, it functioned, but it's horse's immunoglobulin. So my body has a reaction to that. That's why we call them serum sickness. I gave a serum of some other animal, rabbit or horse into my body reacted against that. That's a starting point of type 3 hypersensitivity, right? Type 3 hypersensitivity, to sum up in one word, if someone asks me in a Viva, what is type 3 hypersensitivity response? It's simple. It's characterized by immune complex formation in the circulation. Don't stop with that. Most of you guys stop with circulating immune complex. Circulating immune complex does not have a problem at all, right? Praveen, this is a second year subject. You can look at Pradeep AR Sir video in the same channel. He'll guide you, right? So it doesn't stop with the circulating antigen. Okay, circulating immune complex. It's circulating immune complex which gets deposited on a blood vessel. That is the most important, leading to activation of complement and inflammation, right? Please complete it. Don't stop it halfway. Circulating immune complex getting deposited, activating and destroying it, right? So how does immune complex form and how does it destroy? Again, I have phases. I have phase of immune complex formation, that's first. Phase of deposition, that's second. Phase of inflammation, that's third. Okay, simple words. When you have an antigen, if you're talking about serum sickness, you can give an example of the horse immunoglobulin. If you're talking about SLE, you can give an example of DNA, because in SLE you have anti-DNA antibodies, right? Or an anti-nuclear antibody. And there's an antibody there against it, and this will bind. This binds and it circulates in the bloodstream. Okay, fine. It circulates in the bloodstream. So once it circulates in the bloodstream, it has to get deposited somewhere. It has to get deposited means it has to get deposited in the blood vessels only, right? The moment it deposits the blood vessels, what's going to happen is you're going to have inflammation. What makes them deposit the blood vessel is the second part, deposition of the immune complex, right? If you look at them, the sluggish flow and the outward force, these are two important determining factor of the immune complex getting deposited. When you have a filtration force, like in kidney, the blood is being filtered outside. There's a force, deposits. Synovial fluid, deposits. Skin, I have a hairpin-shaped blood vessels. Whenever I have a hairpin-shaped blood vessel, obviously the flow becomes sluggish and gets deposited. The sluggish flow of the blood and the outward force, the pull force, makes the immune complex from the center go and deposit on the vessel wall. The moment it deposits on a vessel wall, it's considered like a reaction. That's all. My body will respond. It will activate complement because immunoglobulin, right? Immunoglobulin will have the capacity to activate complement. It will attract more WBC, causes endothelium damage. Primarily, in short, it causes vasculitis. That's all. The immune complex in circulation deposits and cause vasculitis. That's it, right? I'm just going to zoom out once again. So it's the formation of the immune complex, the deposition of the immune complex, and activation of the immune complex, which causes the inflammation, which finally ends up in vasculitis. Prototype example, no one will ever forget, is SLE. Fearless Flame also said that PSGN, very important. If you are writing PSGN as one of the example, I want this word to be there. Here, it will be planted antigen. It's not a circulating immune complex. It's a planted immune complex where the antigen deposits in the kidney and I have an antigen antibody immune complex formed in the blood vessel. It's not circulating in PSGN. SLE is circulating by default, right? Serum sickness, we don't have it these days. Arthur's reaction. This is a localized serum sickness. For us to understand what happened, they kind of injected into the skin. It's like your Mantoux test. Something like that is Arthur's reaction. So localized serum sickness. And we cannot forget SLE. That's the prototype example for type 3 hypersensitive response, right? Clear? Perfect. Few more questions before we go into the next topic. Type 4 hypersensitive response. Can anyone tell me? We said that it's T cell mediated. We discussed in the first itself, right? There are two types of T cells. What are the two types of T cells you know? What are the two types of T cells you know? It is CD4 and CD8 T cell, right? Without doubt, it's a CD4 and a CD8 T cell, right? So if I have a CD4 T cell, I have few types of reaction, which is Th1 dependent. CD8 T cell is going to cause destruction. It's cytotoxic T cells. That's other name for CD8 T cell, right? Predominantly is by CD4, and a little bit of CD8 also contributes to type 4 hypersensitivity response. Few words which I expect in an exam paper. It's T cell dependent. Can anyone tell me it's immediate or late? What do you guys think? Is it immediate response or a late response? It is a delayed hypersensitivity reaction. It's a late response. It's not an immediate response. Because from a CD4 to cause a granuloma formation, that is the basics of type 4 hypersensitivity, will take some time. It cannot be immediate, right? It has to be minimum 24 to 48 hours is where you get the response here. It's type 4 hypersensitivity. It is cell mediated based on CD4 and CD8. They are delayed hypersensitivity response. These three are the keywords we look for in an exam paper. Like I said, IgE, immediate, allergy is for type 1. Circulating immune complex for type 3. Antigen antibody reaction in the cell, in the surface or receptor for type 2. We require keywords. If you have that, we are more than happy to tell you, okay, you know the subject, right? There's no one judging you. We require you to answer simple minimal things, right? So first we'll go to CD4, then we'll go to CD8. Whenever you have a CD4 form, let's say there's an antigen there. As usual, your antigen presenting cells presents to a CD4. CD4 differentiates to Th1 subtype. That's very important. The moment it becomes Th1 subtype, what happens? You will have your interferon gamma coming, right? You'll have your interleukin 12 coming, which results in the formation of granuloma. I'm not detailing it here because we have read it multiple places in tuberculosis. I want to write the exact pathogens of granuloma formation here under CD4 based on the marks provided. It's a 2-mark question. Don't waste time. Just write CD4, Th1 results in a granuloma formation. Yes, 5-mark question. I will be able to write, okay, interferon gamma came. It converted a macrophage into an activated macrophage. Activated macrophage combined to form a giant cell. Write all the story of tuberculosis, right? This is exactly nothing but TB pathogenesis. As simple as that. Same pathogens for chronic inflammation, what we saw. I'm not going to repeat it. We'll see tomorrow in detail when you go to chronic inflammation. Okay. Next is Th17 response. CD4 has 3 responses. Th1 is this, Th2 is allergy, Th17 is the other one, right? So whenever an antigen presenting cell presents to a CD4, it becomes Th17. They secrete different interleukins, 17 and 23. The most important thing here is this will bring acute on chronic inflammation. This will bring both neutrophils plus lymphocytes. This is very, very, very classical acute on chronic inflammation in 2 places. See, retrospectively reading general pathology makes lots of sense. Did we read in ulcerative colitis a finding called as cryptapsis? What is abscess? Abscess is nothing but collection of neutrophils. IBD is a chronic disorder. In a chronic disorder, having a collection of neutrophils, it is because of type 4 hypersensitivity and Th17 response. That's what we must have read in IBD chapter in pathogenesis also. Go and have a look. General pathology forms everything in systemic pathology. We have complete systemic. We are just going to the roots now. That's all, right? Psoriasis, there's an abscess called as an microabscess in the skin in the stratum corneum. Same, psoriasis is a chronic disorder, but it'll have accumulation of neutrophils. Monroe's microabscess in psoriasis, a classical finding, right? Then come to CD8. CD8 is cell cytotoxicity. It's a cytotoxic T cell. That's all, right? So what happens if you have a target cell? Generally, it will be a virus. CD8 response for type 4 hypersensitivity is very, very minimal. Just remember it. It also exists there, right? A virus attaching to the FAS receptor attached to the target cell, and the CD8 will be attracted, which will have the FAS ligand. This binding will activate 2 substances, perforin granzyme pathway. Perforin is the things which will put holes in the membrane like perforation. Granzyme is exactly like caspase. It goes inside and causes cell death in the form of apoptosis, right? I'm just writing here. Granzyme is exactly like a caspase which destroys the cell by apoptosis. Again, we'll look tomorrow in detail about apoptosis, right? Few examples. I'm just going down. Can anyone comment on few examples for type 4 hypersensitivity? Whatever comes to your mind. I'll tell about one thing, that is your contact dermatitis we already saw. Anything else apart from contact dermatitis? Anyone? Anyone? There are many examples, right? One of the most important mistake which students do with respect to type 4 hypersensitivity is they sometimes mistake them as type 2 because type 4 will always have antibody production also. Okay, so here we have type 1 diabetes. T cells destroy the beta cells in type 1 diabetes. That's why we have insulin dependency, right? At the same time, when the broken beta cells come, B cell will produce antibodies. We call them anti-GAD antibodies. Just because I have an antibody, it doesn't make it type 2, it's type 4. Great Kalpana. You must have read about rheumatoid factor in rheumatoid arthritis. Antibodies to CCP in rheumatoid arthritis doesn't make it type 2, it is type 4 hypersensitivity, right? Rheumatoid arthritis, where T cells are the primary problem. Contact dermatitis, celiac disease. What can anyone name one antibody in celiac disease? We read about them in the last week. Manto test, great in tuberculosis, right? Multiple sclerosis, psoriasis IBD. Here it is primarily TH17. All these are examples for type 4 hypersensitivity. In an MCQ or in a Viva, if someone asks you what is the type of hypersensitivity, please go to the starting point and not the ending point. In celiac disease, you must have read for sure, you'll have anti-TTG antibodies, anti-transglutaminase, anti-gliadin antibodies. Doesn't make it type 2, it is always type 4 because starting point is T cell causing damage to enterocytes, T cell causing damage to myelination, T cell causing damage to the beta cells, right? All of them will have antibodies, but the starting point is always T cell. Pernicious anemia, T cell dependent damage, and also B cell also contributes, right? Perfect. That's about the type 4 hypersensitivity response. We're done all the classical 4 hypersensitivity response. Like I said, if you want to add extra points from microbiology, as a teacher, I'm more than happy to welcome it. Doesn't matter if it's from path or micro, but I don't know how your examiner will be, but both will have more or less the same concept, maybe extra few examples in different books. That's it, fine. Now, next one, what you're going to see is about graft rejection. Graft rejection can come in a short note. If I want to elaborate it, I can elaborate it to a long answer as well because I have acute, hyperacute, chronic, and also we have GVHD. I can give sections to you, try it, right? Before going to graft rejection, few basic Viva questions which I want to ask. What is the type of graft? The name given if two identical twins have transplant. Two identical twin, one guy has given the kidney to the other person. What's the type of graft? Classical name is perfect isograft, right? So let's say I have a big ulcer in my hand, not healing. I take my skin from my thigh and put it in this place. We call it split skin graft. What type of graft is that? Or I take my blood, store it in the blood bank. After an elective surgery, I give the same blood back to my cells. What type of graft is that? We call them autograft. In the same person, I call it an autograft, right? If I'm going to give a kidney to my brother or sister, what type of graft is that? Is it an isograft? No. Only identical to this isograft is an allograft. What's a term given to a graft? If I'm getting a cardiac valve from a pig to a human being, what's a term given to that? We call them xenograft, right? We have isograft, we have allograft, we have autograft, and we have xenograft. Potential Viva questions because that's a starting point. Once you answer that, then they'll go to the next one, right? Then we have, yes, I need to have a compatibility. If it's a bone marrow transplant, I look for a HLA. If it's a solid organ transplant, I look for the anatomy and the ABO compatibility, right? Perfect. Now, graft has two problems. The first problem with graft is I got a kidney from someone else. My body can reject the kidney. That is rejection. I got a bone marrow from someone else. That bone marrow is killing me. That is graft versus host disease. Either my body can kill the graft or the graft can kill the body. These are the two problems of the graft and we look at both the problems, right? So we divide graft rejection into hyperacute rejection, acute rejection and chronic rejection, okay? In everything what I want you to notice, the timeline. I need to know the timeline without fail. Pathogenesis in simple words. Is there any way to identify them? Is there any way to prevent them or treat them? That's all is required, fine? So here hyperacute happens within minutes to hours. Actually, it happens on the table. When a person operates a kidney transplant, in front of the surgeon, the kidney will fail. It will become pale, it will die in front of the eye. It happens within minutes to hours, right? It should never happen. If it happens, it's a problem of the transplant surgeon there, right? Why it happens is, donors will have preformed, see, the person who is getting the transplant, right, the host will have preformed antibodies against donor. Imagine I'm getting a kidney from my mother. My body has antibody against my mom's blood already, my mom's kidney already. The moment the anastomose, my blood vessel with my mother's kidney blood vessel, the antibody will cause endothelial damage. Because my body has antibody which will identify my mother's kidney's blood vessel antigen to be foreign, goes and binds to them. If your endothelium is damaged, can anyone tell me what's the next step? It will automatically cause clotting, because that's one of the components of virtuous triad, right? So you'll have clot formed, which will prevent the blood from entry into the donor organ. There'll be no perfusion at all. This leads to infarct. Can anyone tell me what type of infarct is this? Somebody just give me a few minutes, it'll start soon. That's a classical coagulated necrosis, right? That's a classical coagulated necrosis, right? Because solid organ infarct. In whom is this more common? It's more common in multiparous women and people who have got multiple blood transfusion. The simple reason being, if a woman has given birth to 5 or 6 kids, right? 5 or 6 kids, what happens is, over the period of time, the woman would have gotten exposed to multiple antigens inside the uterus. So there's a more chance of this happening. And multi-triple transfusion, same chance of them happening, right? How do I reduce this? Like I said, it's a never happen event. It should never ever happen. For me to reduce, before even transplant, I do a test causing preformed donor antibodies. If the antibody is present, you are not eligible for a donor. They'll reject you and look for a new donor. What I see in microscopy, I'll see multiple tiny clots, and like I said, I'll have classical coagulated necrosis. That's what I see in microscopy. Hyperacute, never happen event. I have to avoid them. Right? Second is acute. One important thing here, if you have not read anything and you do not want to make blunder, write this in bold letters. Throughout pathology, acute means neutrophils. With respect to graft rejection, acute means also lymphocytes. There will be no neutrophils here at all, because it's a destruction of a cell. A cell can be destroyed only by lymphocytes. Fine. Acute rejection, both. I have B lymphocytes and T lymphocytes. Both can cause acute graft rejection. It is happening after day to weeks of transplant. How do I know it? The moment I have a kidney transplant, if the kidney function starts reducing after a few weeks, I think of a rejection. Right? One of the blessing is immunosuppressants. Can anyone name one immunosuppressant used in kidney transplant from pharmacology? I'm sure you must have known that, right? One, your tacrolimus, sirolimus, all of them, right? So all those immunosuppressants have reduced the incidence of acute rejection to any extent, right? Here, only lymphocyte will be present. I have cellular type, I have humoral type. Cellular is again CD4, humoral is again antibody production, B lymphocytes. I have tubular-interstitial type in cellular, and I have the necrotic type, the worst type, and vascular types, we call it type 2, which is the seen in humoral, right? So the difference between cellular and vascular. Here you'll have both macrophage and T lymphocyte destroying, because T cells will never act alone, will always require an antigen presenting cell, right? Here, the antibodies can directly bind to the blood vessel and cause damage. It's a circulating antibody, goes and binds to the blood vessel directly and causes damage. That's what happens in your vascular versus a cellular type of a graft rejection, right? So what I see in microscopy, both your cell mediated as well as your antibody mediated will have only one thing, lymphocytes. In humoral rejection, what I'll see is, in addition to the lymphocytes, I'll also see complement proteins. I cannot see complement in microscopy, but I need a stain for it. If you have the stain is C4D, which is very, very important. If C4D is present in the microscopy, especially in the peritubular capillaries, I know for a fact this is a humoral type of graft rejection, right? So if it's only lymphocytes in the interstitium destroying the tubules, it is type 1 cell mediated. If it's vascular type, and you have C4D positive in the peritubular capillaries, that is your humoral type of graft rejection. Why should I know this difference is the question. Because until unless it's useful for me, I'm not going to read. If it's a T cell mediated problem, like I said, treatment varies for me. I go for the immunosuppressants. Tacrolimus, sirolimus, right, cyclosporin, right? Lots of them are there. I go with them. If it's an antibody mediated, these immunosuppressants might not work as efficiently. So what we do, I do plasmapheresis. I need to remove the antibody. I do plasmapheresis for that. That's what happens in your antibody mediated rejection, right? Okay. This is for acute rejection. So what happens in chronic rejection? Chronic rejection is the most common these days. Can come in a Viva or in a MCQ. Why it's become more common? If they ask you, simple. Hyperacute, I'm eliminated it by preventing. Acute, I gave drugs by stopping it or reducing the incidence. Because of that, the only inevitable evidence is chronic rejection. It is inevitable. You cannot stop it. If you're lucky, happens after 10 years. Unlucky, happens in 2 years. That's all. What happens? This word is what I look for. Graft arteriosclerosis. Antibody binds to the antigen, causes destruction, again and again and again causes destruction, right? Mir Hadi, all the best. See you soon as doctor. Fine. So the moment it causes destruction again and again and again, you know for a fact it is TDHF. That's all. Tissue destruction, healing by fibrosis. The same fibrosis happens in the vessel wall also, right? The moment fibrosis happens in the vessel wall becomes extremely thick and there'll be intimal fibromuscular hyperplasia or fibroplasia that reduces the lumen's diameter, reduces the lumen. The moment lumen gets reduced, obviously you'll have your interstitial fibrosis, because blood supply is most important. The blood supply is not there, automatically I'll have interstitial fibrosis. These two words are must to look in chronic rejection. Inevitable, cannot stop, might happen in 2 years, might happen in 10 years. Fine, that's your chronic rejection. We know hyperacute, we know acute, and we know chronic as well, right? Next, about GVHD. GVHD alone can come as a 5 mark, or if it's combined with this, it can be available later. Fine. Okay. Fine. Okay. So hematopoietic stem cell transplant, GVHD, what the most important prerequisite here is, in graft versus host disease, the graft, right? The graft should be immunocompetent and the host should be immunosuppressed, right? The graft should be immunocompetent and the host should be immunosuppressed. This is very, very important for a GVHD to happen. We classify GVHD into 2 types. If something is happening less than 100 days, we call it acute GVHD. If something is happening in more than 100 days, we call it chronic GVHD. Fine. Okay. It happens in few important organs. One happens in your in hematopoietic stem cell transplant. It happens in GI transplant because of Peyer's patches. It can happen, and can also happen in liver and splenic transplant as well. In both of them, acute as well as chronic, it affects only 3 important cells. The easiest way to remember is, wherever I have fastly dividing epithelium, it gets affected. GIT, fastly dividing, skin, fastly dividing, and the biliary epithelium of liver, not liver, the biliary epithelium of liver is fastly dividing, right? So in all these places, we have GVHD. In skin, you have desquamation in acute, it will be peeled. GIT, bloody diarrhea or dysentery, again the entire GI epithelium will be gone. And in liver, obstructive jaundice, because the bile will be destroyed, biliary epithelium will be destroyed, it will block the biliary tract and will cause obstructive jaundice, right? In chronic GVHD, the same skin, chronic is TDHF, scleroderma. Sclerosis in the skin, very common because of more fibrosis. GIT, again fibrosis, stricture and obstruction. Liver, again fibrosis, secondary biliary fibrosis. Acute and chronic, that's all. Acute destroys, damages and removes the tissue. Chronic will cause fibrosis by default, right? If you look at here, both of them are caused by T cells. Again, if it's acute, it is CD8 mediated, chronic is CD4 mediated, because chronic CD4 always requires macrophage and multiple other things to happen, so CD4 mediated. So if I'm able to eliminate the T cells, I can reduce the incidence of GVHD, right? That's a logic here, right? So here, T cells are the primary person which causes GVHD. So we did one thing. Okay, while transferring bone marrow, you remove the T cells, right? We put a filter and we remove the T cells. This will reduce the chance of GVHD without a doubt. But the only problem is, the moment I remove T cells, I'm removing the protection also. So the leukemia came back. We call this graft versus leukemia effect. I'll repeat this. This can be a Viva question. Let's say a person has an acute myeloid leukemia and the treatment for that is a bone marrow transplant. While giving a bone marrow transplant, I made an intervention. I started removing the T cells. The moment I started removing the T cells, what happened was the leukemia came back because there's no one to protect it. The blast came back. That's what's called as graft versus leukemia effect. Fine. Okay. There are a few latest treatment options. We give a therapy called Solarin therapy. Solarin selectively destroys T cells using UV rays, and the Solarin is an agent which is used for psoriasis treatment as well, right? Selectively removes T cells. In this way, I can try to make the incidence of GVHD better. But there's only one way to prevent GVHD. To prevent GVHD, there's only one way: to have an absolute 10 on 10 or 12 on 12 match. That's the only way to prevent GVHD. Fine? Clear? Okay. Perfect. Now let's go to the next one. The next is amyloidosis. I'm going to again ask you questions. I want you guys to answer this. Fine. Okay. Tell me one common example for amyloidosis. One example for amyloidosis. Whatever comes to your mind. Any one example for amyloidosis. There are multiple subtypes, right? We divide them into multiple places. First, how to structure a question. What is amyloid? How do we classify them? We can classify as localized systemic. We can classify as hereditary acquired. We can classify based on what is getting deposited. Is it AL light chain, AA light chain, A beta light chain, like that, right? And then gross. What will happen to the amyloid in any organ? It will become increase in size, as simple as that. Then how do I identify them in microscopy? What are the stains we use for? Is there any treatment option available? That's it, right? Great answer. Myeloma is one of the commonest example, right? Now let's look at amyloid. Amyloid is must to read from pathology books only because you might not see them in multiple other places, right? Alzheimer's, great. Okay. Amyloid is an extracellular, acellular, amorphous protein deposit in multiple organs in the body. That's what amyloid is. That's all. It's a proteinaceous deposit. That's it. Initially, amyloid starts in the perivascular region. This, remember, because it will solve lots of problem when you go to the gross and microscopy. We classify based on etiology, like multiple myeloma, right, where I have lots and lots of increased production of immunoglobulin, so it gets deposited. Or I cannot be cleared through the ubiquitin proteasome pathway, where I have a defective protein. There are two main problems. One, excess production of protein, normal protein myeloma, or there's an abnormal mutated protein, like in Alzheimer. It's an abnormal protein, not being removed, gets accumulated. I can divide it systemic, localized. Thyroid, medullary carcinoma, only here. Localized, Alzheimer's, only here. It's not throughout the body, right? Acquired myeloma and congenital, familial hereditary. We have familial Mediterranean fever, we have amyloidotic polyneuropathy. All these are inherited cause of amyloidosis. Fine, perfect, great. So once it's done, I want you to mention each one of them at least one word. If you can draw a table and write, also is enough. Or if you can draw point wise, whatever is comfortable for, right? AL, A always stands for amyloid. The second letter stands for what is being deposited. L stands for light chain. Seen in multiple myeloma, the most common effect and the primary organ affected is kidney. AA. A stands for serum amyloid A protein. It's an acute phase reactant. So seen in any condition with chronic inflammation. More inflammation is there for lots of time. Obviously, it results in accumulation of the amyloid protein, right? AA amyloidosis, rheumatoid arthritis, tuberculosis, name any chronic inflammation, it can happen. Bronchitis, it can happen, right? A beta 2 microglobulin, seen in hemodialysis, obviously chronic. Over the period of time, slowly this beta 2 microglobulin keeps on accumulating because they're not filtered by the dialysate membrane and it causes your A beta 2 amyloidosis, right? Then we have your same A amyloidosis but familial Mediterranean fever. Here I have a mutation in a gene called as pyroptosis fever. Because of this, there is an autoinflammation without even an antigen. Without even a bacterial, the patient will keep on having fever. Obviously, when this fever, acute phase protein is there, causes A amyloidosis, right? Then I have two things here. One, familial amyloidotic polyneuropathy, where I have an abnormal transthyretin, TTR. TTR is a short form. Abnormal transthyretin, so not able to remove, presence and deposits in multiple places. The same transthyretin, if they are normal, happens in senile systemic amyloidosis. Normal amount, but the patient is living for 90 years. Slowly keeps on accumulating and causes same problem. In senile systemic amyloidosis, cardiac involvement is pretty common. Fine. So transthyretin can cause two. We have A beta 2, we have AA, also two. One is acquired and one is inherited, and we have AL amyloidosis, right? All these are systemic. Everything what I dealt till now systemic. Localized happens in the organ like Alzheimer's. A beta protein, which is the breakdown product of APP, amyloid precursor protein, deposits in the CNS. Same medullary carcinoma thyroid, ACAL. Cal stands for calcitonin. Next, islets of Langerhans in pancreas, right? I'm going to ask you a question. I want you guys to answer. In pancreas, will you have amyloid deposit in the type 1 diabetes or type 2 diabetes? Type 1 or type 2? Amyloidosis is excess deposition of protein. So it has to be in disease which produces excess insulin, not less insulin. So it has to be in type 2 diabetes mellitus, right? I can have it in either insulinoma, where I have deposition of islet amyloid polypeptide. It can be seen in type 2 diabetes mellitus and insulinoma. Please don't write type 1 because excess deposition cannot happen in type 1 because in type 1 there is less production of insulin, less deposition, right? Can come in a Viva. Don't answer immediately. Think for a few seconds and please answer, right? That's what happens here. So we know all the different types of amyloid. Now what you're going to do is, how do I diagnose them? Diagnose always with gross and microscopy. Gross, kidney is the most common organ affected. Initially, I'll have a big kidney. Obviously getting deposit, right? For many years, it will be normal size. When it becomes big, more and more deposition, I'll have an enlarged kidney. This is a clue here. This is for real life, maybe not for an MCQ. Proteinuria, non-diabetic, non-hypertensive, enlarged kidney, think of amyloid. But in later stages, like years of amyloid, surrounds around blood vessel, right? Every blood vessel will become narrow. It will got destruction and you'll end up having a later atrophic kidney. Liver, everywhere is perivascular space, perisinusoidal space of Deci. It's surrounding the sinusoid get deposited, right? Spleen, again, perivascular. But there are two things in spleen. Red pulp, that's the sinusoid. We call them a lardaceous spleen because it deposits like a lake. Lardaceous means lake. White pulp, it's around pals. Pals is called as periarteriolar lymphoid sheath. That's the other name for white pulp, right? Where surrounding every part of the white pulp, like if this is a white pulp, surrounding them, the center arteriole amyloid deposits. So if you look at gross, there will be multiple dots of amyloid looking like a sago, like a millet grain. We call it a sago spleen. Lardaceous and sago spleen both are classical for splenic amyloidosis. Heart, again, it's the same place, subendocardial, sub blood vessel. That's all. It's lethal because the moment it gets deposited subendocardial tissue, that's muscle, right? Subendocardium is muscle, myocardium. Muscle cannot function properly. Restrictive cardiomyopathy. All the Purkinje bundles, bundle of his and Purkinje fibers are there only. They also will be having a problem. So conduction defects. It's one of the most common cause of death during amyloidosis, right? Kidney can fail, won't kill the patient. I can do a dialysis or a transplant. Heart transplant is not that easy, right? So it's one of the most common cause of death in amyloidosis. So how do I diagnose them? I can take biopsy from any organ. If it's localized, if stomach has a problem, take a biopsy of stomach. Brain has a problem, to demonstrate, take a biopsy of that. Kidney has a problem, take a biopsy of that. But in systemic amyloidosis, when it's not localized, where do I take from? I always prefer abdomen pad of fat. Easy to take. If I fail, easy to repeat. Where do I see them? I see them surrounding the blood vessels. I can take from rectum also because rectum has lots of capillary network. Hemorrhoids. That's the reason we have hemorrhoids there, right? I want blood vessels, that's all. Easiest way is abdomen pad of fat. The moment you do an HNE, amyloid is a protein, it will be pink in color. Okay, many things are pink in color. So we have stains. Congo red. In a light microscopy, you have salmon pink color. See, both are here Congo red stains. In a light microscopy, you have an orangish pink color. That is your salmon pink color. The same Congo red, after putting a polarized light, it changes color into apple green birefringence. That's a classical finding in amyloid. You definitely might have a Viva question based on it or an MCQ based on it. And in Congo red stain, under polarized light, you have an apple green birefringence. Do remember them. Electron microscopy for namesake. No one does it. But what do you see in electron microscopy? I can see non-branching fibrils, which is of 7.5 to 10 nanometer size. If you want to remember. Again, theoretical, no use practically at all, right? What's the best way to identify amyloid? Can come in a Viva or an MCQ, which is X-ray crystallography. That's the best way to identify amyloid because X-ray crystallography is the only thing which can give me the protein structure. Amyloids are non-branching beta pleated sheets. Only X-ray crystallography can give me that as a classical finding for amyloidosis. Clear? Any doubts? Do let me know. If not, let's slowly move to the next guy. Any doubt? No? Perfect. Let's go to the next one. Next one is an unconventional topic, but I feel it might come in most of your university exams. That is obesity, because I feel obesity is a very silent pandemic, which is creeping into our society, into every economic status of our society, and we'll see the problems of obesity maybe 10, 20 years later, if not now. Okay, and generally we try to skip obesity. We write random things and we'll see that we'll sort it out, right? I want to you to understand obesity. If it comes in a 5 mark, you should be able to write the pathogens of obesity, right? It's not an important topic, but it's an emerging topic. So I feel if I'm an examiner, I would want my young graduates to know a little bit about obesity. Again, a structure: define it, classify it, give the types, pathogenesis, complication. It'll come in a 5 mark. Very unlikely to ask an essay. Okay. No, Dora. This is for second year students. Okay, perfect. Now, obesity is nothing but an accumulation of excess body fat that is enough to impair health. Generally, people think that if you have excess fat, you're obese. No, it should impair the health in some way or the other. It's not that it should cause stroke. Making you having a knee pain because of overweight is also obesity. How do I grade obesity? Though this is not the best way to do it, but BMI is a universally accepted way to classify obesity. Less than 18.5, underweight, normal weight, and overweight, right? And obesity starts about 25. 23 and above till 25, we call it overweight, not obese. Above 25 is obese, then every 5. Grade 1, grade 2, grade 3, grade 4. Grade 4 is morbid obesity. BMI of more than 40. Patient will not be able to move, right? They'll be like a sitting in a couch. It will be very difficult for even them to have a simple movement, right? Perfect. That's how we classify obesity. We have two types of obesity. We have central obesity and generalized obesity. Problem is, if you are completely obese from head to foot, you have excess deposition of fat everywhere. I am not saying it is good. That is sometimes better compared to central obesity. Many people, what you'll see is there'll be tummy fat. Rest of the body looks lean. They'll think like, okay, only one part is there. No, that is the most difficult part of obesity. The central obesity is actually more dangerous than a generalized obesity, right? This could be a body type. If your parents are a little bit rounded, there is a possibility you also can be rounded. I'm not saying this is good, this is also bad, but at least better of the worst. Okay, so here you have more fat deposition around the abdomen and increased fat deposition in the visceral. These visceral fat are very, 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 very difficult to remove. And that's the most dangerous, which causes all the complication, right? So causes. This is just for textbook. We know what is the cause. This is the cause. Increased intake of food, especially increased trans fat. I want this word to be there. Junk food is the most important thing. Plus reduced activity. That is ordering in Swiggy. Ordering a samosa or any junk food, a chips packet or anything on Swiggy is the reason for obesity. It's acquired is the most important cause. Yes, I do have syndromes. Prader-Willi syndrome is an example of obesity, inherited cause. And yes, there are mutations in leptin gene, pro-opiomelanocortin, and MCR4 receptor. If you write at least leptin, that's good enough, because leptin is the most important cause of obesity. Leptin resistance and mutation of leptin. Fine. Okay. Now, let's see what happens here. In order to understand obesity, I have to understand about the energy balance first. Everything in my body has a homeostasis. Positive feedback, negative feedback. The moment you have more fat, more leptin will be produced. That will cross to the blood-brain barrier and will tell my brain, see, I am more. So what should my brain tell? Activate the negative feedback, make sure I reduce it. The moment leptin goes and acts on the hypothalamic receptors, that stimulates a factor called pro-opiomelanocortin. That's the second mutation, which acts on the receptor MCR4 receptor. That receptor will help me to burn calories, make me walk and move, and also give me anorexic signals. Don't eat more. So this is to counteract the excess fat. At excess fat, leptin went inside, changed things, made me run fast, made me eat less, so fat shrunk, burns the fat. That's the outcome. Obviously, that's the outcome, right? That's a feedback mechanism. This is not a cause of obesity, it's a feedback mechanism. So what's the biggest problem here is this guy. Free fatty acid will not let leptin cross the blood-brain barrier. First important thing. But I have a protective mechanism for that also in the body. The same fat produces something called an adiponectin. That's called a guardian angel. I cannot keep on producing adiponectin. That's like limited amount. It's a good thing, right? Every good thing is in limited amount only. This adiponectin will destroy free fatty acid. For example, I eat a samosa today, free fatty acid. Adiponectin will come, destroy it, and make sure leptin goes, the cycle remains proper. That's the normal energy balance. Clear? So now what happens from this normal energy balance is, when does obesity happen? When obesity happens is, if you're going to disrupt this mechanism, a beautiful normal homeostasis is destroyed, allow obesity. So you start eating lots of junk food. Adiponectin, junk food destroys. Adiponectin, junk food cannot destroy. When the product consumption of trans fat is so high, adiponectin cannot destroy trans fat because they are resistant to destruction, right? Free fatty acids will be very high, which will nullify the response of adiponectin. So what will happen? It will not let leptin cross the blood-brain barrier. So leptin is there in the body, but is not able to sit on the receptor, causing resistance, right? So when leptin becomes resistance, I cannot reduce the appetite because anorexic signals is not there, and I won't have increased activity because brain is not telling you to go and walk. No increase in activity, no anorexic signal. So you become a couch potato, start eating more and more and more, goes into a cycle, and you become obese. Clear? Obesity is not a common topic discussed, but I feel quite a few university exams this year will have a 5 mark at least on obesity. Okay, I'll go up again. Define obesity based on BMI, classify them, write the 2 types, central and generalized, write the pathogenesis, more than enough. Complication, you can write any chronic disease comes to your mind has a link to obesity, because obesity causes systemic hyperinflammatory response, right? Okay, ignore, wait. So obesity can cause a systemic hyperinflammatory response. Can have metabolic complications, can have mechanical complications, can have pulmonary disorder, multiple of them, right? Obesity can alter glucose metabolism. Because of that, I'll have insulin resistance, increases type 2 diabetes mellitus. Obesity will have altered lipid profile, dyslipidemia, increased LDL, reduced good cholesterol HDL, increased triglycerides. Obesity can cause gouty arthritis. Just weight bearing joints, osteoarthritis. You're so huge and the knee joint is not able to bear the weight, right? Osteoarthritis. Gout again it's a metabolic problem. Obesity can cause obstructive sleep apnea. I have more fat here. Okay, if you have more fat here, my throat will narrow when I sleep, will not let me sleep properly. Obstructive sleep apnea, more snoring episodes. Can be very, very difficult sometimes, right? GI disorders. Obesity, because of intra-abdominal fat, it can interfere with the lower esophageal sphincter because they are diaphragmatic crura, right? When there's lots of fat, the crura will not close, allow more of acid reflux and GERD, right? Last but not least, cancer. Like I said, obesity is a pro-inflammatory state, systemic pro-inflammatory state. So there's lots of reactive oxygen species in the body. Reactive oxygen species causes mutation. So there's a risk of cancer, multiple cancers. Again, common things. You can write your breast cancer, your GI cancers, your ovarian cancers, your endometrial cancers. Most of them are linked to the obesity because of systemic hyperinflammatory response, right? I'm zooming out, complications of obesity. You can write a lot of them. Atherosclerosis, obesity is a cause. Stroke, obesity is a cause, right? These are the headings, at least 4 or 5 headings, which I want you to remember, right? Okay, I'm zooming out. That's about the pathophysiology of obesity. Clear? Any doubt, do let me know. No doubt. Let's go to the next. Okay, perfect. So next thing, I'm going to go to Neoplasia chapter. See, in Neoplasia chapter, it's a very big chapter, but if you look hindsight, most of the chapters in Neoplasia are linked to systemic pathology. Right? If you talk about von Hippel-Lindau, I will read that in kidney chapter. If I talk about P53, I read in multiple places. But there are few topics in Neoplasia which are worthwhile asking in an exam, like carcinogens, paraneoplastic syndrome, metastasis, steps, roots, and everything, right? And we'll discuss that importantly, right? Evasion of immune response, very important. We'll definitely talk about them. I'm not going to talk entirety of Neoplasia. We look at the most important topics with respect to cancer, which can come in an exam point of view, right? Generally, the topic of Neoplasia will be asked mostly in the second part of the paper because they are cancers of the GIT. That's important for me. Breast cancer, that's important for me than talking about the general principles of cancer, fine? Okay. First thing was carcinogens. So carcinogen, very unlikely to ask in a long answer. If they ask in a long answer, they'll give you a clinical history and then ask you subdivisions. Define a carcinogen, talk about chemical, talk about microbial, talk about radiation carcinogenesis. Short answer, only microbial also can come in a short answer. Both will come in a short answer, right? That is good. What is carcinogen? See, carcinogen, the first and the most important thing is carcinogen should be chronic. Acute exposure very rarely causes cancer. Unless it's like Chernobyl, it will not cause cancer. Percival Paul is the first one who discovered that chemicals can cause cancer. He rated as scrotal cancer in chimney sweepers because the coal dust went then deposited in the scrotum, not cleaned properly, so it caused cancer. We can divide cancer into chemical, radiation, microbial. In chemical, we divide them to direct and indirect. Fine. Direct acting carcinogens, as the name says, I come in touch with the chemical, it will directly cause mutation. That's what direct acting carcinogens are. Indirect acting carcinogens are something which has to be changed to a carcinogen inside the body. Actually, indirect acting carcinogens are intermediate. They're actually the strongest carcinogens. The most common example is smoke. Smoke is a classical indirect acting carcinogen, right? The activating enzymes are the one which makes them carcinogenic. Like for example, the COP enzymes. That's why some smokers don't have cancer because they don't have the COP enzyme, right? All these are examples of indirect acting carcinogen, not direct activating. Aflatoxin indirect, asbestos indirect, benzene indirect, benzene indirect, right? The only thing which is direct acting carcinogen is your drugs. The drugs used for therapy. For example, you must read about topotecan, irinotecan, right? The cancer chemotherapy drugs, alkylating agents, all of them are direct acting carcinogens. They are weak, they act directly. That's the reason they are used in therapy. Rest everything here example are for indirect acting carcinogen only, right? Unlind is an indirect acting carcinogen. Fine. Okay, perfect. Radiation carcinogenesis. So radiation carcinogenesis, UV rays is the commonest rays. Any ionizing radiation can cause cancer. UV, X-ray, CT scan, PET scan, everything can cause cancer, right? So what happens for me is, when I am exposed to UV rays, you are exposed to UV rays, mutation is bound to happen. One layer of protection is melanin. Second is P53. The moment UV rays happens, we have a problem called pyrimidine dimers or double-stranded breaks. And you have a repair mechanism called a nucleotide excision repair mechanism that will protect me. If this nucleotide excision repair is absent, that's a disease, xeroderma pigmentosa, where you have defective nucleotide excision repair. That will increase the exponential risk of skin cancers. The patient will have lots of cancers in the body. Squamous, melanoma, basal, everything will be there, right? That's a genetic condition, right? So what happens in general if I get exposed to UV rays for quite some time? So there are two types of UV exposure. One, someone who's getting rarely exposed but for an extended hours, like person who's doing sunbathing or an artificial tanning center, right? Causes melanoma, predominantly causes melanoma. Someone is getting exposed throughout the year for limited hours, like us. Throughout the year, I have some amount of sun exposure, right? But maybe 2 minutes, 10 minutes, half an hour, not for like 5-6 hours, right? It's more common, little bit less harmful, seen more of temperate environment, increased risk of squamous and basal cell carcinoma. That's why the incidence of melanoma in India is a little bit less compared to the others. Fine, okay? There are two types of exposure and both of them pathogens is the same. UV rays, pyrimidine dimers, my body has got more than what P53 can take care of it. So, ends up in having cancer. That's all, right? That's radiation carcinogenesis. The next, we'll go to microbial. Like I said, microbial alone can come as a short note. If microbial comes as a short note, write in the form of a table, it's very clear. They'll understand what you're trying to convey. If you're not good in presentation, okay, write paragraph waves also. I want few things. I want you to know the gene or the viral product and what cancer they cause. That is enough for me. HTLV1, there's a viral product called as a tax gene. Okay, the viral gene which increases the proliferation of T cells. So I have adult T cell leukemia lymphoma. HPV, you cannot forget that, right? E6, E7. These are viral proteins. Destroys P53, destroys retinoblastoma, lots of them. I put as anogenital. If you want to make it longer, cervical, vaginal, vulval, penile, anal canal, all of them are related to HPV. Oropharyngeal, nasopharyngeal, right? Yes, we do have vaccines and should be given for both men and women, irrespective of the gender. Now we are pushing it to women because of the cost factor, but if you're a guy who is affordable, please get vaccinated. EBV, a viral protein called an LMP1. Increased risk of lymphoma. I'm just writing it lymphoma. We know that we read in WBC disorder which lymphoma, what subtype, everything we know. Right? Nasopharyngeal carcinoma, gastric carcinoma. Gastric carcinoma is a new one, recent update, know that. Hepatitis B and C. No viral protein. Pure chronic hepatitis. Inflammation can cause hepatocellular carcinoma. HHV8, human caposiform virus, has a viral protein like cyclin D1. Causes Kaposi sarcoma, Castleman, primary effusion lymphoma. These three have been asked multiple times in MCQ, NEET, PG, can come in an exam as well. Fine. Okay. H. pylori. I have two important genes of H. pylori, CAG and VAC. Both are again pro-inflammatory. It's inflammation-related cancer. That's all. Can cause gastric adenocarcinoma or adenoma, and also can cause maltoma. Again, this for an MCQ. Theoretically, H. pylori causes atrophic gastritis, reduce the risk of acid, reduce the risk of acid reflux, reduce the risk of Barrett's, can cause reduction in the risk of esophageal adenocarcinoma. Right? Practically, very minuscule reason. My main concern is it causes gastric adenocarcinoma, maltoma. That's where I'm going to look at more. Right? Schistosoma hematobium. Again, same chronic inflammation. Urinary bladder, especially, it causes squamous cell carcinoma of urinary bladder. Right? Clonus sinensis. These are liver flukes, can cause cholangiocarcinoma, right? All of these are the microbes which can cause cancer. Okay, clear? Any doubt? Tell me. Great, Dan. Hope you must have written it properly. Fine. See, either one of them can come in a short note. If long answer, very unlikely to ask. If they ask, they'll put everything, right? 2 marks for 4 marks for this, 4 marks for that, 2 marks for this. That's all. Then they'll say, right along note on carcinogenesis. Very unlikely because most of your LAQs are scenario based. Unlikely to come in a carcinogenesis. Fine. Okay. Perfect. Let's go to the next one. Next, about a clinical diagnosis of cancer. See, let's say I give a history of some random cancer. Let's assume we have a history of breast cancer. History. Diagnosis is very simple. We ask them, how do I diagnose them, or what are the methods in which approach or diagnose of a cancer? Okay, so I have clinical examination, symptoms, and the most important thing is paraneoplastic syndrome, and blood test, biopsies, pap smears, and everything. If a question comes as write a long answer question on the diagnosis of cancer, please think for some time. It's not that you have to write only from Neoplasia chapter. Colonoscopy is a method to diagnose colonic cancer, right? That's all. You must have gone to ENT postings, examination of vocal cord. Different things, right? So if there's it's a very ambiguous question. It's not having a structure. Think for some times, create a structure, and then start writing. Please don't jump immediately because you might miss some things, fine? Okay. So how do I clinically diagnose cancer? First, most of the cancer presents mass lesion. When I say mass lesion, breast mass, there's a palpable hard mass. And when will I call it a malignant mass? That's very important. If you have a firm to hard mass, which is fixed to tissues, this is how most of the cancers will be. Okay, they are fixed, they are firm, they are hard, they are irregular. Okay, that's one. Terminal stage of every cancer will have cancer cachexia. Can come as a 2-mark question or a viva question. Most of the cancers in the terminal stage, they are pro-inflammatory. They have lots of increased amount of interleukins. There's a new concept also. They have a little bit of new proteins as well, but it's a systemic inflammatory response, which you have fever for 5 days. If you feel weak, imagine the body has fever for entire year. All the body's muscle, fat, everything will be destroyed and will be emaciated. That's a cancer cachexia. Next, cancers can present with symptoms due to physiology. Physiological symptoms. What does physiological symptom mean? For example, I have a tumor in the pituitary from prolactin secreting cells. Can anyone tell me what will be the symptom? I have a prolactinoma. What will be the symptoms? The patient also will start secreting lots of prolactin, and the patient will end up in having galactorrhea. Right? Increased milk secretion from the breast parenchyma. These are physiological related. ACTH secreting tumor, Cushing syndrome. Physiological again. Again, At the same time, I can also have compression symptoms. Fine. When I say compression symptoms, same pituitary tumor. You must read in first year itself. It can compress the optic chiasm, causing visual field effects. Same. A pituitary tumor causing visual field effects. Fine. So I can have a mass. I can have a compression due to the mass. I can have secretion due to the mass. Or terminal stage, I can have cancer cachexia. Or I can have paraneoplastic syndrome. Paraneoplastic syndrome alone can be a short answer. Okay. So paraneoplastic syndrome, what do you mean by paraneoplastic syndrome? It's very simple. Hi. So these are signs and symptoms which cannot be explained by anatomy or the spread or the cell of origin. Prolactinoma is not paraneoplastic, it's symptom. But if lung causes prolactinoma, it's paraneoplastic. Lung causing Cushing is paraneoplastic. Because lung has nothing to do with ACTH or glucocorticoids, paraneoplastic. Fine. There are a good number of paraneoplastic syndrome. If you can remember everything, great. If you can remember few, also write few. First, why it is useful? Sometimes patient will not present as lung cancer. They'll present as Cushing syndrome. It will be useful for initial diagnosis. Patient will present with hypercalcemia, routine blood test. Then they'll go and evaluate it, initial diagnosis. Second, follow-up. Lung cancer caused Cushing syndrome. We did a surgery or a chemotherapy or radiotherapy, destroyed the cancer. After 2 years, Cushing's came back, which means who came back? Cancer came back. It's used for initial diagnosis or it is used for follow-up. Generally, it is used for follow-up, right? Examples of paraneoplastic. Cushing syndrome can primarily be seen in squamous cell carcinoma of lungs. Yes, to some extent, pancreatic. This is optional, but squamous cell carcinoma, small cell carcinoma of lung, don't forget it because they release ACTH-like substances. Hypercalcemia, because PTH-RP is released. PTH-related peptide can be seen in breast cancers, squamous cell carcinoma of lung, must. Other two are optional. RCC and adult T-cell lymphoma leukemia. SAADH releases ADH, seen in small cell carcinoma of lung. Important, right? Again, we have one more thing, question. Lambert-Eaton myasthenic syndrome. We read this in small cell carcinoma of lungs as well, right? In the lung cancer FARRE. Okay, Lambert-Eaton myasthenic syndrome, where I have antibodies against calcium channels, seen in small cell carcinoma of lung. Polycythemia, secretes erythropoietin, RCC, and cerebellar hemangioblastomas and hemangiomas. HCC also. Acanthus nigricans, because first indicates insulin resistance. Otherwise, if you eliminate that, think of GI or internal malignancy, uterine malignancy. Lung unlikely, but GI and uterine malignancy, right? The reason is they'll have increase in EGFR, epidermal growth factor. Because of that, skin becomes thicker. Acanthus nigricans. Trossier syndrome, you'll have thrombus throughout the body, migrating thrombophlebitis. Fine. Sure, children, it will be available in the Med app. Please go and look at it. Which nephrotic syndrome? I'll come to dance. Just give me a second. Trossier syndrome was initially discovered in pancreatic cancer, but actually seen in any cancer with abundant mucin production. Be it gastric, colonic, anything, abundant mucin production, you can have pancreatic cancers. Trossier syndrome, because mucin can activate factor 10 and can cause it. Thymoma, thymus, immunity, 2 autoimmune disorder, pure red cell aplasia, and myasthenia gravis. Fine. Okay. Okay. See, tumor markers. Why is it a misnomer? See, I won't say it's a misnomer ideally, but tumor markers is not always seen only in tumors, so I can call it as a misnomer. For example, we'll look into that soon. I can diagnose cancer with blood test, biopsy, microscopy, and genetics also. If a question comes on cancer diagnosis, include them as well. Fine. Okay. Yes, for free, Chetan. Why are tumor markers a misnomer? The reason is simple. There's a tumor marker called as CA125, right? Dan, can you tell me in which condition you will see elevated CA125, or anyone for that matter? Or let's go with the easier guy, PSA. Prostate specific antigen is elevated in prostatic cancer, no doubt. CA125 is elevated in ovarian epithelial tumors, no doubt. Okay. At the same time, when there's an ovarian endometriosis, CA125 will be elevated. This is classically seen in prostatic cancer. At the same time, when someone has prostatitis, PSA will be elevated. Alpha fetoprotein elevated in liver cancer. At the same time, when I have hepatitis, alpha fetoprotein will be elevated. So it's not only seen in tumor, it can be seen in multiple other places. That's why it is not diagnostic, it's always an adjunct to diagnosis. I cannot say this patient has prostate cancer only with PSA. I can suspect and take a biopsy and prove it. That's why maybe the question came, they are misnomers. I won't say it's completely misnomer. It's not diagnostic because elevated in non-neoplastic conditions as well, not only in tumors, so we call it a misnomer. For example, it will be elevated in endometriosis of ovary. Endometriosis is not a tumor, right? That's the reason they call it a misnomer. Fine, perfect, done. That's about the clinical diagnosis of cancer. Any doubts? Kamran, can you tell me why nephrotic syndrome? I couldn't understand the question. Can you explain? I'll try to answer. Okay, let's start. So now, let's look at next question. That's metastasis. Mets can really come as a long note because met has two parts. If you look at Robbins, the place where all it can go, the lymphatic, hematogenous, roots of metastasis is given in some other place. The steps of metastasis is given in the last part of the molecular hallmarks where we discuss about all the steps. Both combined together is a very potential way for a long answer question. It can come. Fine. Okay, see, nephrotic syndrome is not a common paraneoplastic syndrome. Yes, for few tumors, you can have nephrotic syndrome as a paraneoplastic syndrome. See, FARRE, I'll talk about the most important one for us to clear the exam, right? In the real next year batch, we'll discuss in detail about each and everything which is there in Robbins. Fine? Okay, perfect. So, what is metastasis? I obviously need a definition, right? Definition is there always in the word. Meta is change in position from one place to other. Stasis from one place to other. That's all. Metastasis is defined by the presence of a tumor in anywhere in the body which is discontinuous with the main tumor. That's called as metastasis. For example, if you have a tumor here in the neck and it is spreading and going here to the mandible, it is not metastasis, it's extension. Tumor in the lung, spreading and growing into my lung pleura, not metastasis. Tumor in the lung, growing towards the bronchus, it's spread, that's all, it's not metastasis. It should be discontinuous with the primary tumor of origin. That's very, very important for metastasis. There are cancers which rarely spread. For MCQ, basal carcinoma, glioma. Very rarely benign tumors can spread, which is leiomyoma, right? Cancers generally prefer lymphatics. Carcinomas generally prefer lymphatics. Sarcomas prefer hematogenous, fine? Okay. There are few sarcomas which prefer lymphatics. Again, the out of the ordinary. Scare, synovial, clear cell, angiosarcoma, rhabdomyosarcoma, epithelioid sarcomas. All these are sarcomas which prefer lymphatic route. Okay. Now, this can alone come as a short note or an aviva. Two mark question on aviva. What are sentinel lymph nodes and why are they important? Sentinel lymph node is the first lymph node which will receive the drainage from the tumor. Okay. So let's say there's a breast cancer. Fine. And I have lots of things here. See, there is all these green are the lymph nodes. Fine. And there's a lymph node here as well, the blue one. The green network is the first lymph node which receives the tumor supply. Blue is the after green, blue is there. Maybe everything rest here is blue because axial lymph node has apical, lateral, medial, and everything, right? So all the green are the central lymph nodes. It's not one, it's a group of lymph nodes which receives the drainage from the tumor for the first. How do I identify them? Intraoperatively, you inject into the tumor radioactive dye or a methylene blue. The first color change which happens, that is the central lymph node. You take them, do frozen section. Frozen section will tell present, absent. It cannot say what cancer it is. It will not say, it's fibroid, it's a IDC or an ILC. No, it can tell tumor present or absent. If tumor is present, what should be the treatment? Only the removal of tumor, or along with that I have to remove the lymph node as well. Along with that you have to definitely remove the lymph node as well, right? If it's involving if it's not involving the sentinel node, what should you do? Not involving the lymph node, what should you do? then I can remove only the tumor, right? So here, sentinel nodes actually the use is to decide the extent of surgery. Okay. To decide the extent of surgery, we need a sentinel lymph node biopsy. If the sentinel node is involved, the tumor has gone to the lymph nodes, remove them also. If it's not involved, tumor has not gone to the lymph nodes, don't remove them. That's the importance of sentinel lymph node. It's very, very important. When you go to your surgery postings, you'll definitely understand them in detail, right? Next is, cancers can spread via the body cavity. From the lung, can go to the pleura. From an ovary, can go to the peritoneal space. From the heart, can go to the pericardial space, right? That is spreading via the body cavity. That's also a way of spread of metastasis, right? Few rare conditions, drop metastasis. From the cerebellum, the medulloblastomas can drop along the spinal cord. CNS tumors can drop along the spinal cord and spread along the spinal column, right? That's a classical example. Angio-invasive, not spread, it's angio-invasive growth. It does not spread via the blood vessel. It will grow through the blood vessel, like renal cell carcinoma. It can grow into the renal vein and go to the IVC. Hepatocellular carcinoma can grow into the IVC directly, right? It will grow into the kidney. From kidney here, it will grow into the vein and can spread till the IVC. That's a classical angio-invasive growth, fine? Last but not least, Krukenberg. Krukenberg, two cancers, gastric carcinoma, breast cancer, can go to the ovary. Normally, the route of spread is here, right? So in the stomach, celiac acid, azygos, hemiazygos. That's a normal route. But here, from the stomach, it can go in the reverse direction. Normal direction is towards the thoracic duct. It's here, right? It will not drain down. It will drain always up, right? But here, it will drain in the retrograde fashion and reach the ovary. That is retrograde lymphatic spread. Why does it go? Because both of them will have E-cadherin loss. The tumor cells are not coherent. They are dispersed, so they can go anywhere where they want, goes in the back direction, goes in the ovary, right? That's also classical type of spread, right? Now, we have all the routes of spreads for cancer. Then the steps of meds. This alone can come as short note, define metastasis, define the route of spread of cancers. Or define metastasis and talk about the steps of metastasis. Right? There are 6 steps of metastasis. All of them is important for me, right? The first one is, obviously the first one is invasion. Only when it's invading, we call it a cancer. Then we call it loss of E-cadherin, right? As group of cells, let's assume these are cancer cells. In that, this cell alone has a new mutation. We call it passenger mutation. I have 7, 8 cells here. In that, only one cell alone has an E-cadherin loss. Once the E-cadherin is lost, this will come out individually, right? So driver mutations are the one which causes the cancer. Passenger mutations are the one which helps me to spread of the cancer or growth of the cancer, right? So once E-cadherin is lost, it's free to move. Once it's free to move, it is going down, lots of matrix material there. I have to destroy the stroma, only then I can go to the blood vessel or lymphatic, right? So that's the second step, destruction of the stroma or extracellular matrix. Once there's a tissue invasion, the moment the tumor invades the tissue is a trauma. Trauma will always have wound healing. Wound healing will always have wound remodeling. Remodeling will always have matrix metalloproteinase, collagenase, gelatinase. That collagenase destroys the collagen stroma. It will take months to years to destroy stroma. Slowly, steadily it will destroy. Matrix metalloproteins are created by macrophages. So if I see in a biopsy, lots of macrophage at the invading area, which means the tumor is starting to spread, a bad prognostic sign. Okay, I have destroyed the entire matrix. Now, my blood vessel is here. I have to move here, right? I have destroyed it. How do I move? Epithelium does not move. Skin does not move. Muscle moves. Mesenchyme moves. So that's the next step. Epithelial to mesenchymal transition. Epithelium gets converted to a mesenchymal tissue, a elongated tissue, right? Mesenchymal tissue will have actin. It can automatically move. How do I convert them? With the help of 2 important genes, twist and snail, that can convert a epithelium to a mesenchyme. Then the mesenchyme slowly moves and reaches the blood vessel. The moment it reaches the blood vessel, it will form a tumor embolia inside the blood vessel, right? It comes to the blood vessel surface. Same concept, collagenase comes, destroys the vessel. From outside, it enters inside. The moment it comes inside, it will cause endothelial damage, Yes. Endothelial damage will cause clot. So what will happen is platelets, RBC, WBC, everything will stick and cover the tumor cell. Why are they covering? So I can escape immunity because my body will see a layer of WBC in the blood and not the tumor cell. Tumor cell is there in the center. Rest everything is covered by platelets, RBC and WBC. That's a tumor emboli. And the tumor emboli now rotates in the body, in the blood vessel or in the lymphatics. I have to get out, right? There's only one cell which can easily go out of the blood vessel. That is WBC, rolling adhesion diabetes. RBC can't go outside. Platelet can't go outside. So the WBC, which is there outside the tumor emboli, with the help of CD44, this is a very important marker for lymphatic spread, a chemokine, hyaluronic acid for lymphatic spread. And for breast cancer, I have two important chemokine receptors, CCR4 and CCR7. Right? With the help of them, they get outside. The moment they go out into a new organ, like a lung or like a lymph node, they'll start developing there in a very specific manner. They'll form a cluster. That's the metastatic deposit. In lung, brain, liver, heart, mets are more common than primary. Which means whenever you see a lung cancer, the first thought should be heart should be metastasis, not primary, because they are much more common than primary in these few organs. Fine. Other organs I'll think of primary by default, right? So what are the unique things about metastasis? When I say in these organ mets are more common, I need some signal, right? Okay, when I see this finding, it's metastasis. Mets will always be multiple, will not be single. Mets will always be in the periphery of the organ. If you have lung, let's assume lung, mets will be here. Mets will not be in the center. There will be multiple, they'll be in the periphery, and the most important thing, they'll be very, very, very well defined. Okay? Because there's only one vessel there. They cannot acquire new vessel from here. Only one vessel. We call it feeder vessel. That's a vessel via which the mets came outside. So they will rely only on them. So I have a vessel here. I'll grow like this only. I won't grow like this. I won't infiltrate because I cannot accept a new blood vessel. Always concentric growth. That's why we call them cannonball lesions for lung metastasis or a target lesion in the liver. They look perfect. Because of the excess growth, the central part will have necrosis or an umbilication. Classical. Since I have feeder vessel, if I can give chemotherapy and block the vessel, right? Should use a different color. Chemotherapy and an embolus along with the chemotherapy and block it. It will destroy the entire metastatic clone, right? So these four. The first four are the clues for mets. Peripheral, multiple, well-defined lesion with central necrosis. Classical diagnosis of metastasis. Fine. Okay. I'll zoom out. Any doubt, do let me know. We know about the definition. We know about the exceptions. We know about the routes of spread. We know about the steps of metastasis. Everything put together can come in a long answer, but I would expect it to be short answer generally about the steps of metastasis alone. Any doubt? Let me know. Sorry. I feel evasion of immune response. Also, there's a very likely chance it can come as a 5 mark because again, it's a new concept. Because immunotherapy is something which is rapidly evolving in cancer treatment, and there's a possibility it can come as a short note. Fine. Okay. So the first question is, tumor or cancer is a pathogen for me. So my body should definitely destroy it. The question is, why is my body not destroying it? Because I have superb CD4 cells, superb CD8 cells. They should destroy them. Why are they not destroying them is the question, and that is evasion of immunological surveillance or evasion of immune response. Simple answers. Tumors are intracellular pathogen. Yes, they are problem due to mutation. They are problem inside the cell. They should be eliminated by T cells or NK cells without doubt, because these are the warriors against intracellular organisms like tuberculosis, viruses, right? How do a CD8 cell, how do a tumor escape CD8 cell? How do a tumor escape CD4 cell is what we are going to see. Fine. First, every nucleated cell in my body has MHC1 molecule, right? This MHC1 is the one which binds to CD8. So when I have a infected cell, virus infected, okay, there's an alteration in the MHC molecule. CD8 recognize them. Just now we saw perforin granzyme destroys them. That's why we call them cell-mediated cytotoxicity. Once I destroy the virus infected cell, virus will automatically destroy because virus is an obligate intracellular organism, right? Perfect. This is normal. But what happens in tumor is the moment a cell becomes a cancer cell, they will lose MHC1. I don't have MHC1. Loss or down regulation of MHC1 is one of the classical hallmarks of cancer. The moment I lose MHC1, CD8 cannot even identify me that I am there. Without recognition, how will I destroy it? No release of operant granzyme, no killing. So tumor easily roams in my body without even being seen by one of the most effective cells, CD8 cells. Okay, a full CD8. CD4 should have helped me, no? Why it's not helping me? For that, we'll have to understand how does CD4 function first. For a normal activation of CD4, I need antigen presenting cells and I need CD4. That's my first signal, MHC and T cell receptor. I also have one more signal, that is CD80, 86 and CD28. Both these signals are must for me for CD4 activation. If I, for example, if I don't have this signal, right? I don't have this signal, this second signal. The CD4 cell will not work. I need both the signals for me to activate. By eliminating the second signal is how I protect myself from self-antigen. For example, I fell down, my skin was torn, my skin antigen went into the blood. Antigen presenting cell doesn't know anything, they'll find it present to CD4. CD4 will say, no, this is a self-antigen, right? Self-antigen, don't act against them. So what they produce two molecules, CTLA4 PD1, that goes and destroys second signal. T cell releases two factors. They block the co-stimulatory molecule. When I destroy the second signal, my body cannot react against a self-antigen. That's a mechanism of preventing autoimmunity. We call it energy. This is good for me. But what tumor cells did was, tumor cells also start escaping the same route. They produce CTLA4, PD1, and made my body assume that tumor cells are self-antigen. They are very, very, very cunning. Right? Once they assume tumor cells are self-antigen, automatically they'll be destroyed. Fine. Yes, just ebullient. You can go in the same channel. I have 3 or 4 FARREs for systemic pathology. Just go and have a look at that. Fine. Right? So how do I use this? I know the process, how they escape my CD4. So I use a simple mechanism called immune checkpoint inhibitors. So what I did was, we used the same and we produced antibodies to them. Ipilimumab, nivolumab. These are the first produced drug. We have lots of congeners like pembrolizumab and multiple other things. This goes and blocks CTLA4, blocks your PD1. Once it's blocked, what happens? My body will start recognizing, T cells will start recognizing, it's a cancer, let me destroy them. One of the worst side effect is, yes, there will be increased incidence of autoimmune reactions. There will be increased incidence of ANCA-mediated vasculitis. One of the funny side of it is, yes, you'll have a reversal of aging of thing. Your wrinkles will be gone, your hair will become from white to black. That's a rare finding, but increase in autoimmune reactions and increase in ANCA-mediated vasculitis is something which is pretty commonly used in immunotherapy. We call them immune checkpoint inhibitors, right? The only thing which will work is NK cells. NK cells still can destroy tumor cells. The only thing why cancer is not touched them is NK cell is an innate immune response, not so powerful in destroying the tumor cells. Fine. Okay. That's about your immune checkpoint inhibitors and evasion of immune response. Okay. Fine. Done. I was supposed to take genetics also today. I have the content for genetics also. My throat is cracking a lot. What I'll do is, I'll cover genetics tomorrow along with your first chapter and the inflammation. We'll cover tomorrow the first chapter important questions, second chapter important questions, and also the questions in genetics, right? Any doubts, do let me know. I'm calling it off today. I'll start with, we'll look at Downs, Turner's, Egler-Dunlop's, Marfan's, and your trinucleotide repeat and your genetic diagnosis and others in the next class. Fine. Sorry for it. Throat is cracking a lot. Any doubts? Let me know. If not, we'll cut it short and call it a day. Okay, then. Thank you, guys.